Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh, and a very good morning to all our participants and speakers uh, of the third Emergency Medicine Seminar Series, Part 1, which is on clinical toxicology from Kuala Lumpur, Malaysia. We are in the National University Hospital, and today we will be talking on some issues of clinical toxicology from our speakers, our international speakers. But before we start, I would like to first introduce our two moderators for this morning. The first moderator is Dr. Ashok, and the second moderator is Dr. Magat. Both are our Masters in Emergency Medicine uh, uh, students. And just to inform you, this program of EMSS began in 2017, and we have been conducting various topics to discuss. And for this year, due to COVID-19, this program had to be conducted online. And I believe via technology, we are able to reach more people, more students, more participants, more doctors who are interested in this topic to join us today. So without further ado, I would like to pass the session to our two moderators to begin our webinar today. So without further delay, Dr. Ashok and Dr. Magat. Thank you.
Assalamualaikum and very good morning. Thank you, Prof. Khaldun. First, I would like to welcome to the respected professors, specialists, distinguished speakers, and fellow colleagues. My name is Liana. First and foremost, welcome to our third Emergency Medicine Seminar Series of 2021. This year, EMSS will be divided into two parts. Part 1 is today with the theme of clinical toxicology, and part 2 which will be held next week with the theme of clinical toxinology. So thank you again for joining us. So before we start, I just want to announce few housekeeping announcements for today's session before I pass over to the moderators. Firstly, we would like to ask the cooperation from the participants to mute the sounds during the whole session. Secondly, if you have any questions, kindly provide the questions in the question and answer box, not in the chat box. So we will have a Q&A session after all the speakers giving their presentation. Thirdly, at the end of this session, we will provide you with a link for a feedback form. Upon completing the feedback form, you will receive an email containing the attendance e-certificate. QR code for MMA CPD point for Malaysian participant will also be provided at the end of the session. Okay, fourthly, the webinar can also be viewed via live stream on Facebook of CPC Faculty of Medicine, Universiti Kebangsaan Malaysia. So the link is given in the screen. So without further delay, I will give to Dr. Ashok to proceed with the presentation. And for the participants, just sit back and relax. We hope that our session today will benefit you. Thank you.
So I stop screen share kan. Good morning and welcome to our honorable guest speakers, ladies and gentlemen. It is our great pleasure today to be your moderator for this event. I'm Ashok and Magat, and on behalf of committee members, would like to extend our warm welcome to the third Emergency Medicine Seminar Series 2021 webinar, Part 1 session for clinical toxicology, organized by National University of Malaysia in collaboration with Emergency Department of Philippine General Hospital, Universitas Brawijaya, Indonesia, Remote Envenomation Consultation Services ASEAN, Malaysian Society of Toxicology, and Malaysian Society of Toxicology. This Zoom webinar is also being screened live at Facebook page of CPC Faculty of Medicine UKM, and the link can be obtained from our promotion poster. We appreciate you taking off your, sorry, we appreciate you taking time off your busy schedule to join us. We are proud to say we have prepared for you a very exciting lineup of talks by experienced speakers from Malaysia, Singapore, Taiwan, and Japan. Without further delay, would, I would like to call upon our first speaker of the day. She is a well-known clinical toxicologist and is an emergency physician in Emergency and Trauma Department Hospital Raja Permaisuri Bainon Ipoh, Malaysia. Not only she is the Vice President of the Malaysian Society of Toxicology, she also a panel in the Remote Envenomation Consultation Services, or also known as REX. Her special interest is in clinical toxicology and toxinology. She has multiple research projects and poster presentation, both nationally and internationally. Without further ado, I would like to call upon Dr. Ruth Sabrina to present the first talk of the day on recreational drug abuse.
Assalamualaikum and a very good morning. I hope that you can see my slide. Okay. First of all, thank you to Chairperson for introducing me. And good morning to all the speakers and also the participants. So for today's topic, my topic is about recreational drug abuse. So bear in mind that I have only got about half an hour to explain about the recreational drug abuse. So we cannot actually cover all of the recreational drug abuse. Therefore, I may share a few of the common drug abuse that we encounter, especially in Malaysia, right? Okay. My outline of presentation, first of all, is about drug laws in Malaysia, and the second one is to recognize the clinical features of abusive drugs poisoning and the general approach in managing the poisoning. Right. So in Malaysia, the possession of drugs is a serious offense, and it is we are governed by the drug laws. And as I have listed here, there are about 5 drug laws that is available in Malaysia. So first of the drug law is the Dangerous Drug Act 1952, and it actually governs all the Schedule 1 drugs in Malaysia. And the second one is the Poison Act 1952, and subsequently is the Drug Dependence Treatment and Rehabilitation Act in 1983, Dangerous Drug Act Special Preventive Measures, that is additional act in 1985, and also Dangerous Drugs Forfeiture of Propriety Act in 1988. Right, this is the data that I have encountered in our national anti-drug agencies as latest as 2020, but they have not really published it for the whole 2020, but this is half of the initial data that is available. So for drug abuse in Malaysia, we can see, I'm sorry that this is in Malay because they have not actually prepared it in English, but I will translate to you. So for the drug abusers, most of them are male, which is comprises of 96%, and most of the drug abusers are actually working in the private, about 25%, and Malay is actually affected more, and And the types of drugs that normally being abused currently as the 2020, as the year 2020 is amphetamine type stimulants, which comprise about 60%, and followed by the opioids, which comprises of 36%. Followed by cannabis, hashish or marijuana, 3%, and others comprises about 0.6%. And most of the drug abuses is belongs to the adult groups, range from 19 to 39 years old, and most of them actually is in the secondary schools, which is about 62%. Okay, based from the classification of the drug abuse, so there are many classifications that are available outside there, but for the purpose of learning, so we can classify the drug abuse based on the pathophysiological effect in the CNS. So it would be CNS stimulants, which includes the amphetamine type stimulants, and also cocaine, for example, and also CNS depressants, which includes opioids, benzodiazepines, barbiturates, and ethanol, and also dissociative. For example, the example of drugs are ketamines and PCP, phencyclidine, and also hallucinogens, for example, cannabis, LSD, and also magic mushrooms or psilocybins, and inhalants, which involve certain hydrocarbons. We go one by one. Okay, first of all is CNS stimulants, and we will go with amphetamine first. Amphetamine is derived from the Ephedra vulgaris plant, as you can see over here, and this plant is actually found in 1850s, and actually the plant is also being dried as a herb that we call ma huang in the east, and it is used for increased energy. So, and also the first synthesis of ephedrine was done in 1887 by by one of the doctor from Japan. He's the one who actually found out of the ephedrine. And after that, the evolution of the benzaprine inhalers to relieve asthma. And amphetamine also is popular during World War II. We call it as pep pills to increase the energy in the soldiers at that time. And in 1980s, there are outbursts of designer drugs following the legislation of amphetamine control and medical usage. Throughout the years, the amphetamine actually evolved into being synthesized to dextroamphetamine and also subsequently to methamphetamine. And there are about more than 200 amphetamines derivatives or amphetamine-like substances that is available now in the markets. And for example, the methamphetamine and also 3,4-methyl methamphetamine or MDMA. So we can see over here. This is the example of the methamphetamine that is available, or we call it shabu or ice or glass. There's other names for that drugs, and also this is the example of the MDMA or ecstasy, or we call it molly as well. That can be tempered easily. Yeah, this table one actually showed the common street names of amphetamine derivatives. For those who use the amphetamines, they may not actually call the drugs amphetamines. They might call something else, because if they call I want methamphetamine, if other people actually listen to it, then they might get caught, right? So other than that, also the amphetamine can be substituted with other chain like alpha carbon, beta carbon, to actually exert or improve the effect or increase some effect and reduce other bad effects. For pharmacokinetics, methamphetamine usually in the form of a crystal, and it rapidly absorbed by inhalation, ingestion, or injection. Methamphetamine compared to amphetamines, compared to initial amphetamine, has much greater CNS potency than amphetamine, with long half-life of about 19 to 34 hours, and the onset within minutes. and the duration of effect may last more than 24 hours, whereby the MDMA, the effect normally will begin within 50 to 60 minutes after injection and lasts about 1 to 6 hours typically, and the MDMA half-life of 8 hours and occasionally up to 24 hours. The pharmacodynamics, what are the effects of mechanism of action of the amphetamine? Now that is that it causes release of endogenous catecholamines, basically dopamine and norepinephrine, and at some extent the serotonin, and resulting in symptomatic toxicity and also psychomotor agitation. Of course, there are multiple mechanisms of action involved in the postsynaptic junction, pre and postsynaptic junction, but the cumulative effect is the sustainability of dopamine and norepinephrine in the cleft to exert its effect. The toxicity of the drugs, it can cause symptomatic toxicromes, which comprises of hypothermia, tachycardia, hypertension, tachypnea, mydriasis, diaphoresis, seizures, and other symptomatic sign symptoms, and it can also cause complication to the CNS systems, CVS, metabolic, and also causing pneumothorax and pneumomediastinums. This is well reported in a few case reports in the journal. And the killer of the drugs is normally because of patient develop hypothermia and its complications that cannot be reversed, and as well as CVS complications, whereby patient can develop acute myocardial infarction and also dyspnea and after that death. This is the example of the pneumomediastinums that we can see from the CT scan of the thorax of one patient, amphetamine abuser, and this is the example of the apical pneumothorax and also pneumomediastinum seen from the CT scan. Okay, tweaking is the term to describe psychomotor agitation and psychiatric symptoms. There is some sort of similar to schizophrenia, whereby the patient will be presented with agitation, paranoia, hallucination, and delusion. It actually involves the methamphetamine user, and the greatest danger actually possessed to the drug abusers themselves and also others through violence and also harm act. So as you can see in this video, basically this is the example of tweaking, whereby he's actually talking alone and also carry 2 CDs and pretended that one is dumbbells. So a little bit about MDMA. MDMA causes euphoria, increased alertness, jaw clenching, tooth grinding, or we call it bruxism, and also restless movement. And generally, MDMA has less sympathetic effect, and it has much more euphoria compared with amphetamine or methamphetamine. It may cause significant hyponatremia. So this is the determination of MDMA compared to the methamphetamine or amphetamine. It can cause hyponatremia due to the effect of increased release of vasopressin, and it commonly occurs in the morning, usually after the use of MDMA. And patient can present with signs symptoms of hyponatremia as well. Serotonergic activity of MDMA also is a risk factor for serotonin syndrome, especially when when the patient consumed MDMA in combination with SSRIs. This is the example of meth mouse and also crank bug. So crank bug is when the patient is having delusion of parasitosis and they are trying to crack, cracking their skins, scratching their skins until it's been ulcerated. And this is the typical phases of drug abusers over the times that showing typical features of meth mouse and face. A little bit about MySoT that is called in US or legalized in EU. This is a new synthetic catenols that appears in 2000s, and it appears to be more toxic and and it is one of the NPS drugs that is available currently. So a little bit about NPS. NPS stands for new psychoactive substances, and below are the types of the NPS that is available in the market. Of course, if the patient actually consume a new psychoactive substance, let's say for us in emergency department, if we only have got urine toxicology, for example, the point of care urine toxicology testing, even though it's negative, it doesn't mean that the patient doesn't consume NPS, provided the patient is also presented with signs symptoms of drug abuse, right? So we go to cocaine. Cocaine is the second CNS stimulants that are being used, especially also in Malaysia. It is an alkaloid extracted from the leaf of Erythroxylon coca, which is native in South America, and it is chewed for the stimulant effect. And currently it exists in two forms, which is the cocaine hydrochloric salt. It can be injected, ingested, or snorted, and also cocaine-free base form. This free base form is stable and thus can be smoked. Other nicknames for cocaine is coke, crack, snow, and flake. And cocaine-associated death is related to the arrhythmia, cardiac ischemia, or acute myocardial infarction, seizure, and also CVA. The pharmacokinetics of cocaine is it is well absorbed through mucosa and all parenteral route. The metabolism is by plasma cholinesterase in 50% of the case of the drugs, non-enzymatic hydrolysis in 40% of the drugs to benzoagonine, and also less than 10%, which is actually excreted unchanged in the urine. For pharmacodynamics, the mechanism of action is basically similar to the amphetamine just now, but it blocks the predominant is the dopamine effect, which is it blocks the presynaptic reuptake of biogenic amine, especially dopamine, and also noradrenaline and also serotonin as well. It also has a sodium channel blocking effect, causing QRS prolongation, which we can see from the ECG. It increases the endothelial production of endothelin and decreases production of nitric oxide, which is actually one of the vasodilators. The fatality dose differs from various routes, ranges from 10 to 20 milligram IV to 1 to 2 gram intranasally. Toxicity is the same. It can cause symptomatic effects and sodium channel blocker effects. It can cause dysrhythmia, and it can cause vasospasm. It will enhance coagulation and platelet aggregation and accelerated atherosclerosis, which increase the risk of acute myocardial infarction. The clinical features is basically the same as just now that I mentioned, which actually include pneumothorax, pneumomediastinum, and pneumopericardium, non-cardiogenic pulmonary edema, and also acute exacerbation of bronchial asthma. Other than that, also the complications include ischemic bowel or infarct, rhabdo, and its complications. The common killers include hyperthermia and its complications, and also CVS complications, and also intracranial bleed. Have a look at the cocaine-associated chest pain. In the scientific statement from AHA, Acute Cardiac Care Committee, in 2008, actually, it has been aligned the management of cocaine-associated chest pain, whereby these are the drugs that need to be given. And the management actually is likely similar to our ACS or STEMI, provided that maybe a bit of additional is that to avoid beta blocker acutely, and the rest is basically the same. Why we have to avoid the beta blocker is because of we are afraid of the unopposed alpha activity that can cause further increase in coronary vasospasm, decrease myocardial oxygen delivery, increase in systemic vascular resistance. Okay, this is the example of cocaine bugs, example of a condition that we call a cocaine bugs, whereby the patient is stretching the legs Also, because of the dilution of parasitosis, the feeling of bugs below the skin. A bit about cocaine and ethanol. Cocaine and ethanol is really a dangerous situation whereby it can actually produce coca-ethylene. The coca-ethylene compound is more toxic and stays longer in the body and increase risk of complications further. So what are the acute management in emergency department? So first of all, a good supportive management is very important with assessment of danger response, airway, breathing, and circulations. And after that, actually, if the patient is agitated, we can give benzodiazepines. And if the patient is hypothermic, cooling, whether it's actually external or internal cooling, may be of great help, and also giving the patient's fluids, and also control the blood pressure and chest pain management, and look hard for the complications and manage the complications. Antipsychotics is not recommended for stimulants is because it can lower the seizure threshold, affect the heat disposal, and prolong further the QTC, and can cause acute dystonia and also worsen the neuromuscular, and it can also cause an NMS. We go to CNS depressants. First of all, we will talk about opioids. Opium poppy is one of the opioids that is available. Opium poppy contains several active alkaloids, which includes morphine, codeine, thebaine, and noscapine. Opiate is a substance derived directly from opium poppy plant. Opiate is natural. Of course, the opioid is also currently through evolution. We have in the form of semi-synthetics and also synthetics. Semi-synthetic, for example, is heroin, dextromethorphan, and DF-118. And synthetics is like methadone, tramadol, pethidine, fentanyl, and dextropropoxyphen. Morphine, an opioid agonist, is the classic opioid analgesic, whereby heroin is a semi-synthetic agonist. Is the classic drug of abuse. It is more lipid soluble than morphine and result in a rapid CNS passage and enhance the euphoric effect. We call it as rush. And the common route of administration is IV injection and inhalation, and the effect lasts about 2 to 4 hours. That is similar to morphine. So we have to look for opioid toxidromes. That is the triad of CNS depression, respi depressions, and so meiosis. For respi depression, we have to evaluate both the depth and the rate of the respiration. Others complication that may presented to us in emergency department when a patient comes with toxidromes is that the patient might have acute lung injury. Patient may present with seizure, especially if they overdose tramadol, pethidine, or dextropropoxyphen, or dysrhythmia, or the patient can come with serotonin syndrome in pethidine and also tramadol overdose. The management is again supportive. Ventilation support is very important, and the appropriate use of naloxone are the mainstay of treatment for acute opioid poisoning with a good supportive management. Establish a patent airway and ventilate the patient, and give the naloxone in incremental dose. Right. So what is the endpoint of treatment? Is adequate ventilation, satisfactory tidal volume, and breath rate. All right. When we want to give naloxone, we have to observe for any withdrawal. Vomiting can lead to aspiration, and we have to observe for recurrence of respiratory and CNS depression. Different opioid, depending on their pharmacology, may respond differently to naloxone. Some may respond to low dose, some may respond to higher dose of naloxone. This is the graph that I found in the ASEP now in July 2019, whereby from this graph, the ASEP actually suggested whereby we have to give naloxone or not. one of the method of giving naloxone. And this is the latest update in the American Heart Association 2020 with regards to opioid poisoning and how to approach. This is the approach for lay responders algorithm, and this is the approach for healthcare providers algorithm. If you suspect for healthcare provider algorithm, if you suspect opioid poisoning, check for responsiveness and shout for help. Activate the emergency response system, get naloxone and AED if available, and we will see whether the patient is breathing or not breathing. If the patient is breathing, prevent deterioration, open the airway, consider naloxone and transfer to the hospital, and keep ongoing assessment and reassessment of the patient. If the patient is not breathing, normally, and if the patient has no pulse, and actually you have to proceed with the CPR and also consider naloxone at that time and support ventilation if there are pulse, and also give naloxone. So this is the suggested naloxone based from the AHA 2020 guideline. We'll go to the benzodiazepine. Benzodiazepine is also one of the CNS depressants, and it can cause sleep-like toxidromes. When it actually causes sleep-like toxidromes, the patient might present with complications such as compartment syndromes. There are a lot of benzodiazepines that being abused. For example, in Malaysia, that I've encountered a few times before is the overdose with nimetazepam or Aramin 5. Zopiclone I only encountered once in Malaysia, but during my training overseas, I've encountered a few cases, and others is as stated here. Zopiclone is also a CNS depressant. In massive overdoses, it can cause methemoglobinemia, and subsequently hemolysis or renal impairment also can ensue. And of course, hemolysis and renal impairment takes some time to develop. We go to the third classification of drugs abuse, which is dissociative. First drug is ketamine. Ketamine is the dissociative anesthetic, and it derived from the phencyclidine group. It can actually give the sense of bodily detachment or out of body feel. It can be snorted, smoked, or ingested as a pill. It has variable names, A, special K, vitamin K, Kit Kat, and can be insufflated or ingested. The exact mechanism is still not fully understood, but it is understandable that it binds to NMDA receptors, biogenic amines uptake complex, sigma receptors, and also acetylcholine receptors. Onset of action about 5 to 20 minutes, lasted up to 60 to 90 minutes. And clinical effects actually depends on the drug concentration. When it blocks the NMDA receptor, it can cause anesthesia and cognitive deficit, and also psychosis. When it blocks the monoamine reuptake inhibitor, it can cause hypertension, tachycardia, and agitation. When it blocks the alpha receptor, it can cause lethargy and coma. And when it blocks acetylcholine receptor and GABA, it can cause nicotinic and muscarinic signs of sedation. The clinical features of ketamine toxicity is divided into two, which is acute and chronic. In acute phase, it can cause altered mental status, slurred speech, anxiety, hallucination, distorted body images, nystagmus, and also dizziness. For CVS, it can cause discomfort, palpitation, hypertension, and tachycardia. Seizure or respiratory arrest can occur. Death is rare. Hypothermia and rhabdomyolysis also can occur with psychomotor agitation, makes the patient at risk of self-inflicted injury. When we talk about chronic toxicity, it means that actually patient can take ketamine for quite some time, and it can cause toxicity to the urinary tract, GI tract, ENT, and also CNS. First, we are talking about ketamine-associated bladder dysfunction, which is actually firstly reported in Hong Kong in 2007. whereby the patients use the ketamine from 1 to 4 hours and presented with symptoms of dysuria, frequency, urgency, urge incontinence, and painful hematuria. And the postulated pathophysiological mechanism is a direct toxic effect of ketamine and metabolites causing lower urinary tract inflammation, microvascular changes, and ischemia induced by the chemicals, and autoimmune reaction triggered by chemicals causing fibrosis and structural changes. This is one of the case reports actually by the Hong Kong team with regards to KABD, a report of 10 cases that they encountered. Dysuria actually comprises of 80% of total number of the cases, the presentation, followed by frequency and nocturia and urgency. Ketamine-associated abdominal pain is also not really rare. It is common among heavy users. The users can actually present with regressive pain that lasts from few hours to days with abnormal liver function, and CBD dilatation has been reported. And this is the case reports of the dilated common bile duct mimicking choledochosis in ketamine abusers, and this is actually reversible. For ketamine-induced nasal damage, it is because ketamine, when it is snorted, it can block the nose with permanent loss of smell, and it can also cause nose bleeding, chronic rhinitis, and so septal perforation. So pictures here showing septal perforation. And it can also cause CNS or cognitive dysfunction, whereby it can cause memory loss, slowed psychomotor, tremor, outbursts of temper, hallucination, and impaired abstract thinking. The treatment for ketamine drug abuse is also supportive care, monitor in a quiet environment, adequate fluid resource to maintain urine output, and if the patient agitated, we can give benzodiazepines, and to observe for a period of 4 to 6 hours for the effect of ketamine off. So normally in my center, I normally, because I don't have observation bay or ward, so normally we will admit the patient. We'll go to hallucinogens, the last classification of drugs of abuse. Cannabis. Cannabis is actually derived from the cannabis sativa plant or cannabis indica plant that usually found as a resin or crushed leaves. So it is also known as marijuana, hash, pot, or grass. Cannabis sativa contains more than 400 compounds, and not all of the compound is actually toxic and cause effect. Basically, the major active ingredients is delta-9 THC that are majorly present in the cannabis sativa, and also cannabidiol that majorly presents in cannabis indica. Of course, the THC delta-9 can cause the high kind of clinical features, whereby the cannabidiol effect can cause the stone features. Cannabis can be smoked. Cannabis exert effects via the specific cannabinoid receptor of CB1 in the brain and also CB2 in the peripheral receptors. The clinical effects, majority people consume cannabis because of the relaxation effect. Although in acute phase, there will be a little bit increase in heart rate and blood pressure, whereby in the chronic stage, it can cause a reduced heart rate and reduced blood pressure, causing the patient to have postural hypotension, and it can cause dry mouth. In the long-term run, it may impact memory and impact attention and cause tolerance or reverse tolerance. THC is lipophilic and undergoes enterohepatic recirculation, metabolized in the liver. And if you do a urine point of care testing in emergency department, if you can detect the cannabis, nothing actually special about that, because it can cause a prolonged detection in the urine. Okay, the most recent cannabis drug of abuse that we are afraid is that the emergence of synthetic cannabinoid, which is the K2, for example, spice, and also the fragrance spice, push. So the effect is essentially more potent compared to the original cannabis. Okay, I'm in the end of my lectures. About 2 to 3 slides more. Hallucinogens. Psilocybin is also one of the hallucinogens that is available. Malaysia also have it. This is magic mushrooms that is available. Slightly present on the cow dungs, and provide the feeling of euphoria and sensory distortion, similar to LSD effect by activating the serotonin receptors, mostly at the prefrontal cortex. So this is my last slides. What we gather so far for the management of drug abuse is that in emergency department, our approach is, first of all, is stabilize the patients according to the protocol of ACLS and ATLS. And this is the principles that being taught to us, which is actually, if the patient is sleepy, support the sleepy. If the patient is crazy, cool down the crazy. If the patient is actually is agitated, protect the body. So this is the principles of management in overall. Right. With that, I thank you.
Thank you so much, Dr. Ruth Sabrina, for your informative talk. Let's continue our program today by introducing our next speaker. Our next speaker is a senior consultant in emergency department at Ng Teng Fong General Hospital, Singapore. He is a chairman section of Clinical Toxicology, College of Emergency Medicine. I present to you our next speaker, Dr. Gregory Cham, who will be giving a talk about multiple drug injection.
Hello, how are you? I hope everyone is doing well. My next talk, I have prepared a video because I was very afraid of technical issues. So I hope that the video can be played. And all right, I'm open to any question that you may have at the end of the day. And so you can just sit back and listen to the video. And if you have any questions, then just enter the chat box. Thank you very much. Hello, and welcome to the talk on drug overdoses and poisoning. Toxicology comes from the Greek word toxicon, which means poison arrow. It is not an exact science, and there is very little good evidence base. The patients are usually uncooperative, unreliable, and sometimes unresponsive. Patients may come. Supply with the possible inclusion of naloxone to address respiratory depression. We simultaneously administer life-saving treatment while we set out to determine the nature of the causative drug and assess their risk for causing harm. Having established Hello, and welcome to the talk on drug overdoses and poisonings. Toxicology comes from the Greek word toxicon, which means poison arrow. It is not an exact science, and there is very little good evidence base. The patients are usually uncooperative, unreliable, and sometimes unresponsive. Patients may come in various scenarios, and in keeping an open mind, the discovery of an obvious disease does not rule out a concomitant poisoning, and it is true the other way around. There are 4 large action categories: resuscitation, poison identification, decontamination and rendering supportive care, antidote therapy, enhancing elimination, and the final disposition of the patient. The treatment of most drug intoxications is empirical and supportive. Consider immediate resuscitative measures in a poisoning emergency. The standard A, B, and C apply, with the possible inclusion of naloxone to address respiratory depression. We simultaneously administer life-saving treatment while we set out to determine the nature of the causative drug and assess their risk for causing harm. Having established a safety net, now obtain the history, but it is not always reliable. Check the history from various sources as to what was taken, how much, when, and under what circumstances they were consumed. Look for empty pill bottles and attempt to accurately identify the compounds ingested. Perform a pill count to determine the dose and whether the pills taken were enteric coated or extended release. Look also for co-ingestants and traditional medicines. Alcohol is commonly present and it may compound the presenting scenario. Consider drug interactions and altered absorption, food, medication effect, and some disorders may slow absorption. The physical examination may reveal a toxic syndrome, or there may be other clinical clues to determine the class of poison responsible. The patient's weight may help determine if the dose ingested was toxic, and subsequently the weight may be useful in calculating doses. In search of an autonomic syndrome, begin first with a full set of vital signs. Focus on the mental status, pupillary size and reaction, skin perfusion, dryness or sweatiness of the skin, bowel sounds, bladder distension, muscle power, tone, and activity. Assess respiration. Bradypnea or hypoventilation may suggest the presence of a sedative, hypnotic, or perhaps marijuana as well. A tachypnic patient can imply an underlying acidosis, a stimulant drug, or perhaps lung injury arising from a respiratory poison or irritant. The presence of cyanosis could indicate hypoxia caused from a hypoxic environment, ventilation perfusion imbalance in the lung, or the presence of a shunt. Hypoxia is not always indicated by a pulse oximeter reading, as patients do not look cyanosed in cyanide or carbon monoxide poisoning. Hypoxia is the result of the lack of oxygen delivery. It occurs from poor cardiac output and hence the need to examine the heart. Poor oxygen content, which in turn depends on hemoglobin concentration, quality, and thus saturation with oxygen. And finally, the partial pressure of the oxygen in the blood. An arterial blood gas is important in constructing a differential diagnosis. Diagnose the primary abnormality and try to uncover a secondary process. A number of poisonings appear as metabolic acidosis. Next, try to uncover a hidden respiratory process using Winter's formula. A high anion gap in metabolic acidosis is produced by a number of acid anions. A mud pulse is a commonly used mnemonic. From the same blood sample, try to tease out the contribution from kidney injury, ketoacidosis, diabetes, lactic acidosis, electrolyte abnormalities, or rhabdomyolysis. Proceed to resuscitate the patient. Administer oxygen, intravenous fluids, thiamine, glucose, and then reassess if the lactic acidosis improves. There are various gaps that you could look at. An osmolar gap may uncover an underlying solute like alcohol. The pulse oximeter may provide a lower reading than the blood gas in methemoglobinemia, or the venous PO2 is high in cyanide poisoning. Co-oximetry can confirm the diagnosis of carboxyhemoglobinemia and methemoglobinemia. A chest X-ray will be needed to assess a breathless patient. Hypotension, shock, will need the assessment for hypovolemia. Tachycardia is a normal physiological response to shock, but in association with ARDS, dystonia, seizures, for example, may lead to a consideration for salicylate, phenothiazines, or theophylline poisonings. Hypotension in association with bradycardia may be due to digoxin, calcium channel blockers, and beta blocker overdose. Meiosis with dry skin may result from poisoning from sedative hypnotics, while meiosis with diaphoretic skin may be from organophosphates. An ECG is a very important modality to help diagnose an acute myocardial infarction, the presence of QRS widening, QT prolongation, and various brady and tachyarrhythmias. This is a simple guide to the ECG toxidrome. Poisoning may cause abnormalities of any part of the ECG complex. For example, a sodium channel blocker like tricyclic antidepressants can produce sinus tachycardia, a wide QRS complex tachycardia, or prolonged QT interval. There may be a need for more than one ECG. And here is an example of ECG changes in digoxin toxicity. The diagnosis of hypertension, mydriasis, and fever can be further refined with capillary glucose, ECG changes, dryness or sweatiness of the skin, and an assessment of clonus, hyperreflexia versus muscle stiffness. These simple tests can go a long way in helping such a patient. Atomic is the mnemonic that we could use for the differential diagnosis of altered mental states. A is for alcohols, which are often present along with other poisons or drugs. T is for tomogram, which implies the need to search for a neurological diagnosis. O is for the lack of oxygen. M is for metabolic processes, for example, hypo or hyperglycemia. I stands for infection or hyper or hypothermia. C stands for cardiac etiologies. A neurological examination begins with the capillary glucose. Dextrose, naloxone, or thiamine may be needed to reverse neurological effects of hypoglycemia, opiates, and ethanol withdrawal. Subsequently, diagnose the presence of localizing signs, as this could mean the presence of a structural brain disease for which a CT brain is required. Other than the chest X-ray and CT brain, trauma X-rays may be needed depending on the circumstances. An ultrasound examination may be used to diagnose cardiorespiratory symptoms. The ultrasound is not sensitive or specific enough to diagnose the presence of gastric contents. Conditions such as organ failure, glycemic abnormalities, pregnancy, and thyroid diseases make up metabolic causes for altered mental states. Thyroxine excess or thyrotoxicosis may present with hyperthermia. Dry skin may be due to anticholinergic drugs, while a similar presentation with sweaty skin may be due to sympathomimetics. Clonus, again, hyperreflexia and muscle stiffness may be due to serotonin syndrome, while cogwheel rigidity, lead pipe rigidity may suggest a neuroleptic malignant syndrome. Malignant hyperthermia occurs after specific triggers like halothane or succinylcholine. Fever may also be due to salicylate poisoning, and perhaps even more importantly, from infections. Hypothermia could result from sedative hypnotics or myxedema. Subsequently expose the patient. Caustic burns may be visible. Oropharyngeal burns may occur from caustic ingestion. Needle tracks may result from parenteral administration. Some substances are absorbed through the skin. Thus, search for medication patches, for example, nicotine patches. Organophosphates, benzene, phenols are absorbed through the skin. An autonomic toxidrome may be evident on the skin. Purpura or bullae formation may occur, and the presence of snake bite and subsequent wound breakdown may be evident on the skin after a case of envenoming. Paracetamol and salicylates are common overdoses. Their levels are frequently screened in suicide presentations. Levels are usually available from the hospital laboratory. They and the following drug levels have an impact on the further management. Dialysable drugs like lithium, theophylline, anticonvulsants such as carbamazepine, valproate, phenobarbital are amenable to dialysis. Anticonvulsant levels, including phenytoin, should also not be allowed to fall below therapeutic levels. Toxic alcohols and worsening acidosis from salicylates or metformin could also be dialyzed empirically. Other important levels that affect management are digoxin, iron, coagulation, methotrexate, and carboxy and methemoglobinemia. Limit the amount of poison that can be absorbed by decontaminating the patient as soon as it is safely possible. Appropriate attention to the route of poisoning, the technique of decontamination, and complications are necessary. Care should be taken to avoid cross-contaminating other healthcare staff. Inhaled and surface poisonings are easily decontaminated. Eye irrigation, soap and water are regularly used. Do not attempt chemical neutralization of acids or alkalis. And use calcium gels for hydrofluoric acid burns and polyethylene glycol to decontaminate phenol burns. Good supportive care remains the mainstay of treatment. An antidote may be administered. An antidote may be administered if applicable and if benefits outweigh the risk. The duration of action of the antidote should outlast the duration of the poison and its ongoing absorption. Some drugs may have pharmacokinetic properties that are amenable to various techniques of removal, either by multi-dose activated charcoal, forced diuresis, or hemodialysis. In planning the disposition of the patient, consider the need for psychiatric or social help. In an unknown drug ingestion, be cautious of an early false negative. Observe the patient for 4 to 6 hours after exposure and repeat the examination. Enteric-coated drugs, sustained-release drugs, paracetamol, anticoagulants are other examples that have delayed onset of toxicity. In a pediatric patient, one pill can sometimes kill. For example, calcium channel blockers and oral hypoglycemic drugs. It remains a challenge to simultaneously weigh resuscitative interventions, poison identification, decontamination, and provide antidote therapy as well as other techniques of enhanced elimination against the pressure of limited time and evolving clinical acuity. Hi, thank you for playing the slide. I truly apologize. I thought I would be able to solve some technical issues, but instead I think I brought on other technical problems. In any case, I will send the slides to the organizers, and then or you can email me. I left my email in the chat, and I'll be happy to send you a copy of the slides. Also, then you can replay the lecture later through the Facebook link or something like that. Now, what I didn't cover enough of was GI decontamination. I think it's a very large topic. And in performing GI decontamination, there is brought with a lot of complications because of the risk of aspiration. So aspirating or trauma arising from the insertion of a tube for lavage is actually quite real. So there are a lot of problems with doing GI decontamination. There's probably another chapter, another lecture to talk about. But yeah, if there are any questions, I would be happy to address them. Or if later on the organizers instruct that there's another session for Q&A, then I'll be happy to answer any question.
Thank you, Dr. Gregory Cham, for a fantastic detailed presentation regarding multiple drug ingestion. We're going to have a Q&A session later in around 11:15 a.m. We are going to take a short break now. The lecture will resume in about 10 minutes later. Thank you.
We would like you to join us for the second session of Third Emergency Medicine Seminar Series 2021 webinar on Clinical Toxicology on 22nd April 2021. And please do fill up the feedback form via the link that will be given at the end of this webinar. The e-certificate of participation will be emailed to you upon completing the feedback form. The QR code for CPD points will be given at the end of the seminar. Welcome back, ladies and gentlemen. Let's continue our program today by introducing the next speaker. He is the current director of the Division of Clinical Toxicology in Taichung Veterans General Hospital and a consultant of Taiwan Poison Control Center. He has board certificates for emergency medicine, critical care medicine, and occupational medicine. He has special interests in clinical toxicology and toxinology and holds the authorship of a number of academic publications in snakebite management. Without further ado, I would like to call upon Dr. Yan Chow Mao to present the next talk on toxic gas inhalation.
Oh, hello, I'm Dr. Mao. Can you hear me now?
Yes.
Okay, thank you. Thank you. I'm from Taiwan Taichung Veterans General Hospital. Because the time is limited, so I will talk about 4 typical case scenario about the toxic gas inhalation and the the differential diagnosis. Here is a timer. In the evening, 6 patients visit an index hospital because of irritant gas inhalation on the following day. 15 patients were sent to Taipei Veterans General Hospital, and 1 was then hospitalized. The majority of patients have chest tightness, dizziness, and skin itchiness examined in the index hospital. In the Taipei Veterans General Hospital, similar effects were observed. The majority have eyes irritation, chest tightness, dizziness, and skin itchiness. The summary of the clinical effects of the 24 patients reviewed: 71% have eye irritation, 75% have dizziness, and 79% have skin itchiness. Some have chest tightness too. The management, according to the manufacturer statement, there was about 40 kilogram ammonia gas leaked immediately. In the following days, a total of 62 patients were examined at different hospitals. Because it is a multiple causality incident, we arranged a scene investigation 1 week later for better understanding the mechanism of injuries. The factory is near a river in Taipei City. There are many old tanks put or stacked on the ground. Serious corrosion at a pipe or junction was known. Okay, the plant near the tanks withered after the gas leak. You can see the leaf is withered. The lotus and the fish in spots were dead after the gas leakage, the dead fish, and the patient packed their eyes because of irritation and pain. Here is a concentration and healthy factor of ammonia gas. Only 5 ppm is the odors ratio. 50 ppm leads to eyes and airway irritation, thus eyes pain and the chest tightness. In very high concentration, it may cause rapid death. Okay, there are various classifications of the toxic gases. Here we talk about asbestos first. 2 types of asbestos are frequently talked about. They are simple and systemic asbestos. Simple asbestos displaces environmental oxygen and leads to a low oxygen status, for example, methane, nitrogen, propane. While systemic asbestos interfere with oxygen transport in hemoglobin or utilization in mitochondria. They are CO, cyanide, azide, and H2S. In the second scenario, in the high technology industry, 2 young men, A and C, were coma soon after entering big tank containing Toxomer CD830 developing solution. B enter after A and the C enter after B. The D and E entered to rescue the former 3. A and C received CPR immediately at the scene for about 30 to 40 minutes. However, A and C had OCA on arrival at the emergency department. The picture showed central cyanosis and the pink foaming sputum in the tracheal tube, suggestive amedema. The survivors didn't smell any solvent, almond, or rotten egg odors. The artery block gas of the 5 victims shows severe CO2 retention here, and the respiratory acidosis in A and C. The toxicology screen test show no solvent and cyanide. The plasma glucose level of the deaths, A and C, is very high. Yeah. Okay. According to the MSDS of Toxomer CD830, it contains only sodium bicarbonate, sodium carbonate. some non-toxic surfactant and waters. What is the cause of their deaths? Let we see the event happen in West Africa first. There are several craters or volcanic lakes. We will talk about Lake Nile. Lake Nile was here. In 1986, the lake color changed and thousands of animals died in one night. Here is the original lake color. Here is the changed color. Here are the pictures taken 2 days later. The government allowed the scientific team to enter the place for a scene investigation and examining the survivor and deaths. There are several interesting findings, including the people and the animal grew up without struggling, no seizure activity, no insect activity for at least 24 hours. The food utensils were stuck orderly. The survivor 3 to 10 kilometers away from Lake Nile spontaneously awakened 6 to 36 hours later, displayed dizziness, stress, and dyspnea confusion. And one said her kerosene lamp was out and she could restart it immediately. Okay, the environmental and patient toxicology screen showed no increase in CO hemoglobin, no subhemoglobin, only mild elevation of methemoglobin, but no cyanide, ammonia, CO, hallucinate gases, and the sulfur compound in the environment.
本省大楼5楼，火警探测器动作正在确认中，请勿慌张，并请注意下一次广播。
Sorry, there is
探测器不动作。
They are aware that much CO2 liberated from the lake during small volcanic activities, a mechanism like that you shake the Coca-Cola bottle violently. An estimation of 50 meters thick CO2 river suddenly flowed down to the village near the mountain. Therefore, a total of 1,700 people and more than 3,000 cattle died immediately. All animal life was killed, including the insect. Finally, CO2 poisoning was rarely reported before 1972. The first case involved 2 injuries with 1 death during the worker moving a tank into a paint store. Here's the laboratory finding: rapid recovery of the asbestos without CO2 retention. The survivor complained headache, dizziness, and whole body soreness. Before the Lake Nile incident, there were several smaller massacres, including 34 deaths in Lake Mamnon and 142 deaths in Lake Dien. They all near the Lake Nile. However, in the industry country, CO2 poison is uncommon and rare. The mechanism of CO2 poisoning may not only be simple asphyxia, as textbook said. They involve change buffer system and the reaction with peptide, protein, and amino acid. It stimulates sympathetic system and causes respiratory depression and the narcotic-like effect when the concentration is high. In animal study, when high concentration CO2 mixed with normal oxygen, it causes the initial stimulation of cardiovascular and respiratory system. Then this system failed and death come. It stimulated sympathetic system first, then the parasympathetic predominate when the concentration continuously to rise. Okay, the highest CO2 concentration in human case was recorded in an anesthetic accident. A 46-year-old male who received cosmetic surgery under general anesthesia with mask ventilation for hours. He didn't recover the conscious after the procedure. Therefore, he was sent to the emergency department. On arrival, the CO2 level was 375 millimeter mercury in his blood. His CO2 decline was fast in 5 minutes with manual ventilation. His consciousness recovered on the second day of admission. CO2 have multiple toxic effects on body organs. It induces dynamic EKG change in both animal and humans. It induces respiratory stimulation when the concentration up to 8%, but it suppresses respiration when the concentration gets higher. In certain cases, it could induce chemical pneumonitis. Multiple occupational casualties from CO2 exposure were reported. It involved a 7,000 cubic meter CO2 spill into a 8,000 cubic meter space. The incident led to 3 cases lost consciousness immediately, and one of them had acute myocardial infarction. In addition, 2 have pulmonary edema, and 1 received swung against catheterization. It was proved that he had non-cardiogenic pulmonary edema. CO2-induced hearing loss, decreased complex activity, or psychomotor excitation when the concentration rises. In the past, the psychiatrist treat patients with high concentration CO2 because it could induce rapid loss of consciousness. It may also induce transient hypoglycemia because of sympathetic stimulation, just like that in our case A and C. Here is a summary of environmental CO2 level and the health effect. When the CO2 concentration is high, despite the O2 concentration is normal, it could induce convulsion, coma, and death. But we still cannot link the cause of death to the blood CO2 level in this OCA patient because CO2 level is believed to be elevated after death and is not interpretable. We move back to the 5 victims after exposure to the Toxinology solution. What happened to them after exposure to this substance? We suppose that the CO2 was high in the tank when it is under direct sun exposure. In a car, the temperature could elevate up to 80 Celsius degree in 6 hours. How about tank filled with sodium bicarbonate? However, such a suspicion was not proved in this case, and how to prevent another tragedy is unknown. And therefore, we don't have another tragedy so far. Okay, in the third scenario, in the evening at a MySoT plant, a family worked overtime because the son was going to marry 1 week later. The mother didn't get out the barrel when she tied the MySoT vegetable. The little daughter went for check, didn't get out too. The eldest daughter went into the barrel and didn't get out. The EMT arrived by 10 minutes later and took 30 minutes for rescuing. Sent them to the index hospital. The mother and the little daughter was OCA. The eldest daughter had shock and respiratory failure, so sodium nitrite was given at the emergency department. Then she was transferred to our hospital. On arrival, only the physical examination is normal. Only a large epithelial defect of cornea was found. No gas eye present. On the third day, we make a point to see the workplace. There are many large barrel and concrete barrel here, and concrete pool at the workplace under scaffold. Many pipes stand at the corner of the pool. Cement concrete in a diameter of 1 meter were put on the top of MySoT bunch to extrude the water outside the MySoT. Salt was sprayed layer by layer between the MySoT bunches. Therefore, the water contains very high concentration of salt. The MySoT was shown here. The pool is very deep, 5 meters in depth and 3 meters in both width and length. The pipe is designed to release the biogas during manufacturing process. Because the MySoT bunch is heavy, so they first tied the bunch to the nest manually and then use the crane to lift up the bunch outside the barrel here for further processing. because the barrel is 2 meters in depth and 1.5 meter in diameter. Here is a master punch is in the nest. The workers have lifted up many master punches on that day without any problem. When they went inside again to tie the master punches near the bottom of the barrel, they didn't get out one by one. At the moment we see the patient, we knew it is hydrogen sulfide because the typical odors. Hydrogen sulfide is one of the most common lethal gases. It usually happens in swine confinement facility, new collection system, municipal sewer or sewage treatment plants, or any place with decayed organic materials. The mechanism of CO2 H2S poisoning was assumed to be result from cytochrome C oxidase inhibition at the heme-containing macromolecule. However, other mechanism involvement, such as dose and route-dependent respiratory paralysis, the apneic response could be blocked by lidocaine, and the peripheral receptor in the lungs seems to be responsible for the apneic reaction. We can smell H2S at a concentration of 0.01 ppm. When the concentration elevates, it paralyzes our olfactory system. When it further elevates, a knockdown effect occurs. Respiratory arrest could happen within 1 to 2 breaths. The toxicokinetic of H2S is little known. The toxic effects may result from either of the 3 sulfide species, H2S, HS, or sulfide ions. The clinical diagnosis of H2S is not difficult. By the history, it happened in a confined space with any organic material in decomposition or corruption process. Sometimes it happened in hot spring with different mechanisms of H2S production. If we test the patient blood sulfide level, the test must be done within 2 hours because it rapidly eliminates. The urinary sulfide level may be high, but it is influenced by diet and the nutrition status. Low urine level may arouse severe or lethal H2S exposure because it has no time to metabolize. At the incident area, we measure the H2S level with a handheld machine. In this master punches barrel, after lifting the punch, H2S level immediately reach above 500 ppm. 1 minute later, it remains very high, more than 400 ppm. The O2 concentration is normal. The CO2 and the ammonia levels are high, but non-lethal. The treatment of H2S poisoning is mainly supportive. Sodium nitrite and hydroxychloroquine are probable antidotes. HBO, hyperbaric oxygen, or exchange transfusion are seldomly required. Unlike cyanide salt intoxication, there is no evidence that H2S intoxication would confer a risk on the rescuer during mouth-to-mouth ventilation. Okay, the fourth scenario is a 37-year-old previous health male who lost consciousness during cleansing a fermented tank in the pharmaceutical industry. Here is workplace of the accident. The entrance of the tank is very small and that makes rescuing very difficult. The height of the tank is about 3 meters. Here is the inside of the tank. According to the manager of the industry, the tank was completely empty without any fermented debris. But the valve or N2 pipe was on, probably before the worker entered the tank. He was found unconscious for unknown duration, maybe 30 minutes. Although CPR was performed immediately when he was pulled out, the brain CT showed diffuse swelling with apparent loss of right matter junction 6 hours later when he was transferred to our hospital. Patient finally died from central failure 1 month later. Here is the oxygen concentration and human health effect. When the oxygen concentration is low enough, loss of consciousness may happen quite fast, for example, within seconds. However, the original reference cannot be found properly because there were ethical concerns to do such a test on human cases. In the final slides, we will learn knockdown effect. That means rapid loss of consciousness when human exposed to toxin. That is not necessary to be H2S. Several other toxins cause knockdown effects such as cyanide or even CO2, NO2, nitrogen, propane, etc., depending on their concentrations. We make some take-home message. If patients have rapid loss of consciousness after contact with certain gases, we should keep in mind that these agents may cause loss of consciousness very quick when their concentrations are high enough. They are asphyxiant, highly toxic inhalant, including nerve agent, and extremely low oxygen status. Thank you very much.
Right. Thank you so much, Dr. Mao, for your informative speech. Next, we're going to introduce our next speaker from the land of rising sun. He's an associate professor in Division of Forensic Medicine from Tohoku University, Japan. He completed Master of Science in Molecular Biology in Tohoku University before pursuing the Doctor of Pharmacology with the concentration Analytical Toxicology, Analytical Chemistry. He received the Bradenberger Matsumoto Award 2016 from Japanese Association of Forensic Toxicology. He actively involved in multiple organizations such as International Association of Forensic Toxicologists, Japanese Society of Legal Medicine, Japanese Association of Forensic Toxicology, Japanese Society of Clinical Toxicology. We welcome Associate Professor Dr. Kiyotaka Usui. Webinar is all yours.
Okay, thank you very much for your kind introduction. Can you hear me well?
Yes.
Can you hear me?
Yes, Doctor.
Okay.
Yes, we can hear you.
Okay, thank you. Okay, I'd like to thank the organization for inviting me to speak here today. So my theme of my presentation today is analytical toxicology with special focus on forensic science. Okay, forensic science is an academic discipline that applies the theory and the technology of natural sciences to criminal investigations and helps judges to determine guilt or innocence in court proceedings. Okay, in recent years, crimes have become more complex and sophisticated. And in order to solve a crime, substantial academic knowledge and skills are required. Therefore, forensic science can be considered an interdisciplinary research field. And the biggest mission of forensic science is reconstruction of a crime. Herein, the purpose is to scientifically reproduce or recreate criminal acts committed by the criminal in the past. Okay. In Japan, forensic science is classified into criminalistics and forensic medicine, two major disciplines which contribute to solving crime acts. The criminalistics is mainly conducted by the police organization and focuses on physical evidence. I previously worked in this field. On the other hand, forensic medicine, where I'm currently placed, focuses on the autopsy and the death investigation. Okay, first, I'll explain criminalistics in Japan. Okay, in Japan, criminalistics is performed in the forensic science laboratory of each prefecture police. And basically, each laboratory has 5 divisions. The forensic medicine division is responsible for determining the blood type, DNA fingerprinting, etc. The engineering division is responsible for incident analysis, etc. And the criminal profiling and the polygraphs are performed by the Criminal Psychology Division. The Documental Division is responsible for assessing handwriting, etc. And finally, the Chemistry Division, of which I was a member, is responsible for evaluating drugs and poisons and identifying trace evidence from a crime. Okay, I'll now introduce the Division of Forensic Medicine at Tohoku University. The definition of forensic medicine. Okay, the definition of forensic medicine is the application of medical knowledge to questions of law affecting life or property, including ascertaining and certifying the cause of death. The main tasks include performing autopsies and post-mortem examinations to answer three main questions: the time of death, cause of death, and manner of death. At Tohoku University, death investigation is conducted by a forensic team, primarily composed of 5 academic disciplines. These include forensic pathology, forensic toxicology, and forensic radiology, which are used to determine the cause of death. Additionally, forensic dentistry and forensic genomics are mainly employed for personal identification. And I'm in charge of forensic toxicology, so I'll explain a part of my tasks. Okay, drug abuse. There are several illegal drugs available. We detect and quantify these drugs from biological samples, such as blood and urine. And the medicine, in case of suicide, homicide, and medical malpractice, we identify and quantify any medicinal agent that may be employed. A considerable number of medicines are distributed and used in many places, and these need to be extensively screened. And household chemicals. We also identify causative substances in poisoning cases that involve household products like detergents, agrochemicals, and insecticides, etc. And natural toxins. Frequently, accidental ingestion of poisonous foods like poisonous fish, mushrooms, and plants can occur. In these cases, it is necessary to identify the causative substance from biological samples and leftover foods or drinks. As a side note, poisoning by natural toxins has regional characteristics. For example, the common poisoning in West Japan is pufferfish poisoning, and the common poisoning in East Japan is mushroom poisoning. So I believe it's crucial to be aware of these trends in your place of residence. Okay, and chemical weapons. In Japan, terror attacks with chemical weapons such as sarin and VX have occurred in the past. Malaysia also. In the case chemical weapons, we also identify their chemical agents and the decomposition products. And a fire incident, in this kind of incident or arson case, we determine the kind of fuels used, identifying the fuels from the fire debris. And the analysis of carboxyhemoglobin is also important, as this measurement can determine whether the fire was set when the victim was alive or after death. Okay, considerable number of crimes skillfully using poisons and drugs are still reported in Japan. To date, I have analyzed several of poisonous substances shown in this slide. Incidentally, what do you think are poisons? What do you think? So ages ago, there was a famous alchemist named Paracelsus. This painting is a portrait of Paracelsus. I took this picture at the museum in Belgium. he said like this. Yeah, that's true. Then what about water? Is water poisonous? So if you consume a large amount of water, it can cause water poisoning. So accordingly, all substances can be target compounds in toxicological analysis. Okay, here I will present a serial murder case that took place in Japan and in which the dose and the metabolism of a drug were skillfully used. I believe case history is shown here. Please read yourself. And one was killed with aconite poison. And the other victim was murdered using a medicinal agent and alcohol. So what kind of medicinal agent do you think was used without raising any suspicion? The answer is acetaminophen, an extremely common medicine. FEFE is metabolized to conjugates such as glucuronide and sulfate in regular metabolic pathway and excreted in the urine. If FEFE is consumed in large amounts or repeatedly administered in doses that exceed the therapeutic dose, the metabolic pathway is altered to the P450 enzyme system as shown in this slide. Co-ingestion with alcohol facilitates the induction of this alternate pathway. Moreover, even in this pathway, the active metabolite is conjugated with glutathione and excreted in the urine. However, excessive FEFE depletes the glutathione and accumulates NAPQI. Okay, then NAPQI binds to cell proteins and damages organs. And eventually, it leads to death. Okay, so this case illustrates a claim that skillfully utilized the drug dose and the metabolism by simultaneously administering the medicinal agent and the alcohol. Okay, now I'll simply explain about procedure for toxicological analysis. First, it is important to collect as much information as possible. In order to identify causative substances effectively in a shorter duration and using limited sample, information should be gathered from the police as well as from medical and autopsy reports. However, in several cases, no useful information is available. And next, a visual inspection is performed, assessing color, odor, precipitation, foaming, etc. Next, simple tests are conducted based on the gathered information and the visual inspection results. And based on the results of visual inspection and the simple tests, the obtained results are confirmed by performing hyphenated mass spectrometry like LC-MS and GC-MS for qualitative and quantitative analysis. And finally, the obtained information is combined with results of instrumental analysis to arrive at the precise conclusion. Okay, as forensic samples are limited, blind analysis results in a waste of valuable samples as well as a waste of time. Therefore, it is important to evaluate the case outline and accordingly strategize how to proceed with the analysis, especially when the causative substance is unclear. The information can be divided into clinical report, police report, and autopsy findings. In a clinical report, causative substances may be inferred from clinical symptoms and physical abnormalities. In a police report, various hints are given from the situation at the crime scene. There are many information such as containers left on the scene, empty package of drugs and poisons, and the smell of the site, etc. And an autopsy finding, for example, from the color of the postmortem lividity, carbon monoxide poisoning is suspected if it is bright red, and the hydrogen sulfide poisoning is suspected if it is greenish, etc. Okay, the sample selection is also extremely crucial, as the distribution of toxic substances in the body differs depending on the substance. The ideal sample also tends to differ. Furthermore, the suitable sample to be collected depends on the time from the ingestion of a toxic substance to sample collection. It may be more valuable to analyze urine than blood if a considerable amount of time has passed since the ingestion of the toxic substance. However, how about the order of analysis? If you could obtain all samples shown in this slide, which evidence would you analyze first? Now, of course, leftovers. As leftovers that caused the problem present a high possibility to detect something poisonous at the high concentration level. It would analyze this. I would analyze these samples first. But some students answer blood or urine. However, drugs and poisons in the body are basically metabolized or degrade, and the concentrations tend to be lower than those in leftovers. Accordingly, these samples present greater challenges in detecting the causative substance. Therefore, samples such as leftovers are the evidence that the forensic toxicologists consider most ideal. However, criminals tend to discard this evidence quickly. Hence, before the criminal throws away important evidence, it is crucial to collect evidence at the earliest for quickly solving the case. Okay, let's now move on to the analytical stage. After gathering available information and formulating an analytical plan, it is finally time for analysis. At first, a visual inspection is conducted. Appearance, recording the appearance in detail and obtaining images important for later criminal trials. Odor. Is there any characteristic odor or acrid odor? And a color. If a control sample is available, compare the color of sample with control. And a pH. Is the sample acidic or is it alkaline in nature? Okay. And assess the precipitate, stomach contents, and foamness, etc. Okay, now this question. Here is the stomach content corrected in a forensic case. Based on these stomach contents, what kind of substance do you think the deceased ingested? What kind of bluish products are present around us? For example, in Japan, products such as paraquat, mesomel, and glufosinate are known to be bluish to prevent accidental ingestion. And additionally, phentrozepam, hypnotic, is bluish when dissolved. Although there exist several bluish products, considering substances frequently encountered in the field of toxicology, we can narrow the target list. So I recommend that you keep track of the appearance of toxic products around you. Okay, given the evidence, I detected phentrozepam and then confirmed the fetal levels of phentrozepam and its metabolites in the blood of the deceased. So even in the absence of any information, it is possible to narrow down suspicious substances by visual inspection. Okay, now let us consider another case. Please read this case history yourself. Okay, in this picture, the gathered evidence is on the left hand. On the right is the control sample. Okay, so let me show you the results on visual inspection. Brownish precipitate was observed in the evidence bottle. This was absent in the control sample. This implies a high possibility that something was mixed into the tea and it homed when shaken. This means high possibility of containing surfactants. What kind of products are containing surfactants? Detergents, agrochemicals, and disinfectants, etc. are containing surfactants. And there is no peculiar smell in the evidence, which means it is unlikely that organophosphorus agrochemicals and chlorine type disinfectants exist. So based on visual inspection results, what substance should you first target for toxicological analysis? Please recall where this case occurred. Okay, my first choice was disinfectants, which include surfactants. I further narrowed down possible agents to frequently used disinfectants in clinical settings. Okay, in Japan, frequently used disinfectants in clinical settings include chlorhexidine, benzalkonium, and benzethonium. Hence, I evaluated the presence of these disinfectants by LC-MS. The figure above is a chromatogram of each standard. Okay, the lower is a chromatogram of the sample T. Retention times of C12 and the C14 of benzalkonium matched, and each mass spectrum, like a fingerprint of substance, confirmed that the sample T was laced with benzalkonium. Okay, accordingly, in some cases, the target compound could be narrowed down by visual inspection alone. Okay, this is a newspaper article. In the past, a serial murder case was reported at the hospital in Japan, where patients were killed by mixing a disinfectant into IV bottles. Benzalkonium was found to be employed in these murders. Unfortunately, incident or accident by disinfectants occasionally occurs in clinical settings. Okay, after visual inspection, simple tests followed by instrumental analysis are performed for confirmation and quantification. However, owing to time constrictions, I will skip the section of simple test and instrumental analysis. But even in the simple test and instrumental analysis, instead of analyzing indiscriminately, targeted analysis based on the obtained information and the results of visual inspection is very important. Okay, now let's move on to consideration of results. Okay, post-analytical consideration is an extremely important step because the truth and the content of the case or incident will change greatly depending on how the analysis data is considered and interpreted. Okay, there are some precautions to be considered during toxicological analysis. Okay, today we will focus on following two cautions. First, more than one type of poisonous substance may be present in a given sample. When toxicologists detect one poisonous substance, they may feel relief and assume that the causative agent has been identified, thus concluding the analytical procedure. And the second, quantitative values in the analysis do not always reflect the initial concentration at the onset of poisoning. Okay, accordingly, a precise consideration is required to ascertain the truth, as drugs or poisons are always changing. Okay, I will discuss these pitfalls with examples. Okay, this is the case history. A woman and her husband arrived in Naha the capital city of Okinawa Prefecture. 3 female friends joined her at Naha Airport and took plane to Ishigaki Island. However, her husband canceled his trip at the last minute, stating urgent business, and stayed back at Naha Airport. After checking into hotel, the woman suddenly began to experience discomfort and was transported to the emergency department, but died. At autopsy, no specific findings were detected. The husband had been previously married 3 times, and 2 ex-wives had died in a similar manner. Okay. The toxicological analysis revealed that the biological samples of the deceased contained aconitum alkaloids. However, police were unable to arrest her husband because there was the relatively long lag time between the point when the victim left her husband to meet her friends and her death. This needed to be accounted in the context of the known mechanism of aconite toxicity. Police could not arrest him because of his convincing alibi, even though aconitum alkaloids detected from her biological samples. Okay. What trick do you think the husband employed to secure his alibi? He definitely used aconite as the poison. Actually, he also simultaneously used toxin named tetrodotoxin. Aconite is toxic by opening sodium channels. In contrast, tetrodotoxin closes sodium channels. The action of the 2 poisons were suppressed by the non-competitive antagonistic action. Eventually, when the tetrodotoxin decomposed, the toxic effect of aconite emerged. Her husband had the adjusted onset time of poisoning by using 2 different types of poisons. And that was his trick. In fact, her husband had performed repeated animal experiments using mice to determine the best ratio of aconitum and tetrodotoxin for extending time of death. So in this paper, it was confirmed in mice experiments that the time of death can be controlled by varying the dose of aconitum and tetrodotoxin. Accordingly, forensic toxicologists need to be aware that multiple types of poisons can be simultaneously employed. Okay, the second pitfall, changes in drugs and poisons, is mainly divided into 3 phases. The phase 1 includes changes until the sample is corrected, such as postmortem changes of drugs and poisons. And the phase 2 corresponds with changes during transportation and storage, from sampling until inspection. The phase 3 includes changes during analysis and can be attributed to human error. Okay, I'll present each of these phases with examples. Okay, a typical example of phase 1 is the postmortem changes in drugs and poisons. It is well known that drugs and poisons are produced or decomposed in the body with progressing putrefaction after death. Especially alcohol is produced with progressing putrefaction. Hence, alcohol consumption before death should be carefully certified. And it is also well known that high levels of drugs accumulated in organs are released with time, causing diffusion and redistribution, resulting higher blood levels than those present at the time of death. Due to this phenomenon, quantitative values should be cautiously ascertained when determining the cause of death. Okay, let me introduce a phase 2 example from a published report. Please read it yourself. Okay, in this case, the local police detected a small amount of cyanide in the remaining canned coffee drink. However, the police could not detect counter ions like sodium or potassium ion. In this case, can it be concluded that the mixed substance was cyanide? What do you think? Okay, let me go straight to the point. The canned coffee was not laced with cyanide, but it was laced with isobutyl nitrite, which produced a small amount of cyanide. The detailed mechanism of cyanide production is as follows. So isobutyl nitrite decomposes into isobutyl alcohol and nitrite. When the produced nitrite and the organic compounds present in coffee react under acidic conditions, cyanide is produced. Later, these organic compounds were identified as polyphenols, such as chlorogenic acid and tannin. Okay, here in you can understand the careful consideration is required to arrive at the precise conclusion. Okay. This is an example of phase 3. Changes in phase 3, which occur during the analysis and due to so-called artifacts. In Wakayama Prefecture, a poison case occurred wherein 63 people began vomiting and then complaining of stomach aches after eating curried rice served at the community summer festival. And despite medical care, 4 people died. And the local police announced that the cyanide was detected after assessing the stomach contents of victims and the leftover curried rice. However, the medical observations did not fit the typical symptoms of actual cyanide poisoning. Something strange, right? So the National Research Institute of Public Science also began their investigation, and they detected high levels of arsenic, not cyanide, in the curry sample. They concluded that the criminal used arsenic oxide. The findings of the local police were clearly a case of misidentification. Why did this occur? This illustration depicts the simple test procedure for cyanide detection. Cyanide in specimens is extracted by the microdiffusion method using a Conway diffusion dish. Yeah, like this. The evidence sample is placed on the left side here, the sulfuric acid on the right side here, and the sodium hydroxide in the center circle here. Okay, these substances are partitioned by a glass wall. Then the dish is tilted to mix the sample and the sulfuric acid. In the presence of cyanide compounds, such as potassium or sodium cyanide, hydrogen cyanide gas is generated according to this chemical equation. And the hydrogen cyanide gas is trapped by sodium hydroxide solution in the center of the dish. And then finally, the extracted cyanide is tested by color development. However, local police directly conducted the color test without performing the extraction step. And what happened? The detection reagent react with cyanuric acid present in the saliva and showed a host positive reaction for cyanide, although the original did not contain any cyanide compounds. Okay, Cyanocyanic acid is a compound that interferes with color development. This table shows concentrations of cyanide and cyanocyanic acid in the blood and the saliva of healthy human subjects. Okay, the plasma and the saliva contain high levels of cyanocyanic acid. Therefore, the extraction step is crucial to avoid false-positive reactions. If the local place had performed the analysis in accordance with the correct procedure, this kind of error could be avoided. Okay, finally, in conclusion, the following are the characteristics of toxicological analysis. There are some pitfalls in toxicological analysis. The complete history of the sample is unknown. The sample volume is extremely limited and rarely or never available once depleted. Moreover, it is natural that the condition of the analytical sample implying evidence is really poor. So owing to these characteristics, analytical toxicologists are required to accurately interpret their analytical results. Okay, that's all from me. I'm very sorry for taking a long time, and thank you for your patience and cooperation. Thank you.
Thank you, Associate Professor Dr. Kia Toka Usui, for the very interesting presentation. Arigatou gozaimasu. And thank you for all the speakers for your amazing presentation. We are going to take a short break now. We're going to take a break about 10 minutes, and then we're going to resume with Q&A session. Kindly send your question and which speaker is dedicated to via Q&A link in this Zoom page. You can find Q&A link at the bottom of this Zoom web page. You may also send your question via Facebook live chat book. Thank you. So sini pun boleh juga.
Pause je lah.
Pause ya. we're going to start the Q&A session at 11 a.m. sharp lah. Before that, we would like to promote 11 Congress of Toxicology in Developing Country, organized by Malaysian Society of Toxicology on 13 to 16 June 2021. All detail can be obtained from the promotion poster. Kindly scan the QR code and register there.
We would like you to join us for the second session of the third Emergency Medicine Seminar Series 2021 webinar on clinical toxicology on 22nd April 2021.
Welcome back, ladies and gentlemen. Let's continue our program Q&A session. Right. Before that, kindly open your webcam. For all the speakers, kindly open up your webcam. Okay. The first question is dedicated to Dr. Ruth Sabrina. Right. There's two questions, mostly related. Is vaping considered as recreational abuse? Number one. And number two, has doctor encountered any case of poisoning involve vape-infused recreational drug? Example, cannabis, magic mushroom. And can doctor share their experience? Thank you.
The first question is about opinion about using vape as a tool for substance abuse.
Yes, correct.
Yes, correct.
That's correct. Is vaping considered as recreational abuse?
Yeah, so normally the vaping, the drugs that is the that use the drugs abuse, meaning that they use the substance that considered as drug abuse. So I think it should be considered one of the methods of consuming drugs of abuse. So because vaping is not only the vape nicotine, right? In some of the case reports that actually present being written in the journal, there are actually case reports presented that the vaping content, including the synthetic cannabinoids and also fentanyl derivatives, which is a few of the NPS substance. So yeah, that is my opinion from the literature search in the websites and journals. With regards to whether I have managed vaping related to NPS drug abuse currently in my center, I haven't encountered any. But I'm not sure whether we are not good enough in actually asking proper history taking. So sometimes the patient came in with in collapsed states or requiring intubation when presented initially in the emergency department.
Thank you, Doctor. Okay, the next question is to Dr. Gregory Cham. Can doctor comment on usage of multiple dose activated charcoal in managing patient with opioid overdose if naloxone not available?
Hi. Thank you for the question. Few things. One is multi-dose activated charcoal. The use of this modality in trying to reduce absorption is actually quite controversial. Some drugs undergo enterohepatic recirculation, then maybe there's a chance theoretically to capture and absorb the drug on the second pass when it comes back into the stomach through the bowel. That's theoretical, but whether it has whether it's actually beneficial or not is very hard to show a benefit in clinical cases. So yeah, there is not much evidence support for using multi-dose activated charcoal. On the other hand, if the patient has an opiate overdose, then the primary problem is that the patient is unconscious, they have respiratory depression. So trying to administer oral activated charcoal, I think that would be quite dangerous because then they will aspirate the drug. They aspirate the charcoal. So the best case scenario is if you don't have any access to naloxone, then you need to support the respiration, either bag the patient, provide some oxygenation or BiPAP or some other modalities to maintain oxygenation. And then if not, if the patient is comfortable, is supporting his own airway and respiration, then just wait until the effects of opiate wear off. The third thing I want to say is that naloxone has a short half-life. So if you give naloxone and then the half-life is shorter than the duration of the drug. Some drugs are still in the stomach, so their patients are still absorbing it. And some drugs have, some opiates have longer acting half-life. So giving 1 or 2 doses, you may get a temporary response, but subsequently the patient may fall back into the same unconscious state with respiratory depression. So the mainstay is still supportive care. I hope that answers the question.
Okay, thank you, Dr. Gregory Cham.
Any of the other speakers or panelists would like to comment on that as well? Maybe the use of charcoal, activated charcoal. Is there an issue with gastric emptying time with activated charcoal? Or is there some drugs we can use even especially for those which absorb in the small intestine? Maybe we can give rather than just waiting for the gastric emptying time. Greg, you want to comment about that?
Okay, yeah. So some drugs, they interact, and so they may, like opiate, for example, may reduce the may prolong the gastric emptying time. So it remains in the stomach for longer. But I think in any kind of multiple overdoses, large doses, salicylates, for example, they tend to stay in the stomach. They reduce their own gastric emptying time. All this is theoretical. I think so. If there is a benefit, you think that there's a benefit that is greater than the risk of aspiration, then you should be able to give some activated charcoal and hope for the best. And whether these scenarios are studied and published, I think that there are very few. So it's still very empirical science, and we think that it is helpful by giving activated charcoal, but ensure that the patient has got a good airway, is not going to aspirate the charcoal. Otherwise, then we end up with greater problems.
Thank you, Dr. Gregory. We have a next question to Dr. Sabrina. Okay, is there a role of magnesium sulfate in amphetamine toxicity? As amphetamine causes surge of catecholamine, whereas magnesium sulfate can be used in some disease that trigger catecholamine storm.
I think I have answered before, but we would like probably hear from Dr. Yan or Dr. Gregory regarding the magnesium sulfate in symptomatic, amphetamine symptomatic toxicity.
I think, the magnesium may have a very little role in the treatment, except if you are dealing with a torsades, then yeah, torsades then maybe, but otherwise, as an antidote or other thing, I don't think magnesium. I'm not sure. I've not tried it before. Any other inputs? Anybody else?
Dr. Yan, in Taiwan, do you give magnesium? And also, I would like to welcome Prof. Deng from Taiwan as well. Thank you for joining us. Feel free to respond to the questions.
Okay, we don't give magnesium for stimulant overdose because magnesium is very expensive here.
Okay, we have other questions.
All right, again to Dr. Mao, is there any future to differentiate carbon monoxide and cyanide poisoning if unable to obtain cyanide blood level?
Excuse me, CO, cyanide, and another is
carbon monoxide.
Carbon monoxide. Okay, carbon monoxide, we can check the CO hemoglobin level. Cyanide, we can check a cyanide level in blood. Both could be done in our hospital. But in the scenario, CO happen in the incomplete burning process, usually happen in the fireplace or burning charcoal, something else. But cyanide usually happen in industrial poisoning. So the clinical setting is quite different. If we know patient burning coal in his house, we can smell the smell of burning. So we can differentiate CO poisoning and cyanide poisoning based on the physical examination and the toxicology screening too.
Thank you, Doctor. Okay,
I think there are questions from Arifin Arjanto regarding the tox database. He's asking about do you have any equivalent of toxbase.org for guidance in managing poisoning, or do you use different advice system? I think I will answer for our current system in Malaysia. So basically, in Malaysia, we are using, we have our National Poison Center currently in Penang, in University Science of Malaysia, and also one budding center in Islamic University of Malaysia. In the USM, they are using toxins and also micromedex. I'm not sure about tox-based currently, but in the Ministry of Health side, with presence of clinical toxicologists or specialists with special interest in clinical toxicology, we have toxins database that been prescribed under the College of Emergency Physicians. Yeah, I'm not sure in other country.
Can Dr. Gregory comment any equivalent database in Singapore?
Yeah, we use Toxbase. It's pretty well updated. So that's our main go-to reference. We used to use Micromedex, but that's very unwieldy and a bit expensive. So I think for the information that is given, I think Toxbase is pretty excellent.
Our Malaysian pharmacists also in tertiary hospital, they are using Micromedex also as one of the source of information.
How about Taiwan, Dr. Yan? Is there any available guidance system?
Call Dr. Yan.
Dr. Deng is quite familiar with the guidance system because the system is built up by him in Taiwan.
Yes. Prof. Deng, maybe you want to comment how the system for references poisoning in Taiwan you developed?
Well, I'm not quite sure the focus of the question yet, but maybe because you asked me to give you about 5 minutes talk, maybe can I do it right now? I mean, probably will give you some idea about what happened here. Would that be possible?
Yeah, sure. Why not?
Okay. Well, see, we are the medical doctors. We are dealing with any poison cases. I mean, particularly to come into the emergency. So to make a timely diagnosis and provide timely treatment is the most important for all of us, all of the emergency doctors. So in order to be able to handle this situation, approach this kind of situation, so-called more systemically, we need information. I mean, to identification assessment, some the exposure assessment. And we also need analytic toxicology. You just heard from Dr. Usui from Japan, right? Of course, we are medical doctor. We have to rely our own judgment, experience as well. I mean, because the analytical result, may not be able to reach our hand within 2 hours or so. So I would say, to build up information like we have information system. Like we have a poison center here in operation in Taiwan for more than 35 years now. Well, I think in Malaysia, I don't know what kind of situation you have, what kind of status are you in right now. But I would say, I know you guys are very experienced medical toxicologists, clinical toxicologists. However, in terms of analytical toxicology and the information providing information data collection are still quite some space to uh, to reach about. So, but but again, I mean, talking about in nowadays we are in the status of globalization. So, like Malaysia, you may import a lot of the good material, merchandise from international, right? You also export to somewhere around. So, like Taiwan, we import from Europe, from America, or from Japan. We also have our own domestic product like pesticides. So as I emphasized earlier that in order to make a early diagnosis, which will then allow us as a medical doctor to provide the treatment. So we also generate our own data bank. We also generate our own data bank here. Well, data bank, again, we like to do identification to understand what is the active ingredient the patient has been exposed, so on and so on. So you may think about this for your country, and but I do like your symposium or workshop, which this is my first time to join you. I think it's been very good program. You understand that when we dealing with the poisoning as from the medical center point of view, when we try to organize a symposium or workshop, we try to target on what is the most common poison issues, and also some of them maybe the outcome is much more severe, or some issues is uprising, like the drug abuse issue. I mean, drug abuse has been also very important, I think, in your country. So which is quite good. I mean, you have the first speaker actually talking about the drug abuse, which is it's very fascinating to us. So I think what I didn't see here is maybe you need to think about to present some so-called poison outbreak investigation. Poison outbreak investigation, because like Vietnam, Vietnam, they have some issues of botulism, which involves quite more than 1,000 or 2,000 cases. Some kind so-called outbreak, poison outbreak investigation, which actually need to be, discussed in the future. I think today also very important, like the general approach, how to approach all of those poison patients, which also a very good introduction, But I think you also need to be able to think about some kind of like maybe so-called mass casualty, which maybe happen. I mean, the same as that happened in Japan, and we thought maybe some days maybe happen in Taiwan. So I think this is also needs to be to be focused on, because particularly terrorism attack, and that is which may be able to cause a mass casualty, and how are we going to to face the challenge this to be discussed. So again, let me summarize what I learned from this morning. I mean, I think this is very good program, and I do hope that your group can, I mean, my group, our group can be working more closely with your group in terms of the idea and experience exchange is communication. And we should think about, how to organize, like a similar program you have today. And we maybe simply we can bring more some of the case report, and maybe can focus on some particular issues each time, maybe once every couple of months or so, we can have some discussion together. Well, thank you very much. Thank you.
Thank you, Prof. Deng. I think that's a very good input, and I think very fascinating initiative that we should be thinking about. And that's what one of the question is also asking if we are able to kind of share resources in terms of expertise. Let's say a case in Malaysia, we don't have the capacity or capability to analyze certain things. Can we perhaps link up with Taiwan or even Singapore or even Japan? In the region that can provide us the answer to our problems. So that's one. I think we are actually in a stage where we can share a lot of knowledge together and can benefit our patients anywhere they are. So I think Dr. Greg has been doing these talks rounds every month. Is it every month? Every last month, 1 week?
Every second Tuesday.
Every second Tuesday, and he's very happy to invite us all to join his talks rounds every Tuesday. And I think this is going to be maybe a regular event that we can organize for our students and for our doctors. Thank you, Prof. Deng, for that input. So I pass back to our moderators if there are any other questions or other speakers who would like to add on.
Thank you, Prof. Deng, for the thoughtful input and the closing remark. We continue with another question. There is some participant who are interested in the field. This question to Prof. Dr. Kiyotaka Usui. Okay, there is one participant who are interested in your field of expertise. So maybe you can guide him to specialize in your field. I mean, what can he do after medical school or degree? And then another question is also to Dr. Kiyotaka Usui. So the question is, currently, what are the most common poison that are mixed up to cover up further forensic investigation? Thank you.
I think Prof. Usui is not available at the moment. He's having a meeting with a student, but you can direct the question to him directly by email. But for the first question, definitely analytical toxicology is something very new. Forensic toxicology needs to be built up in our region. Well, especially in Malaysia, I think we need to really look into this because it's a very important component. It's not just at the emergency side that we see trying to make a decision about a patient, but the analytical toxicology in the forensic side can actually benefit us in even before patient die. So we can actually do the analytical component of toxicology. For example, Dr. Mao in Taiwan is very active in doing analytical toxicology for live patient, not dead patient. So maybe Dr. Mao, he's actually building up his toxicology unit in Taichung, Taiwan. Dr. Mao, would you like to add on a bit about how important your work in analytical toxicology for patients, acute patients?
Sorry, Dr. Mao, can you on the audio?
Okay.
Is that okay?
Yes, doctor.
Okay. I can see the screen, but that's fine. Because the touchstone approach is very rough. We cannot know each patient, the specific treatment of each patient. So we build up a lab in our hospital to test the toxin. However, the toxin, the type of toxin is large. It's very large amount of toxin. We cannot do every test for every kind of toxin. But for example, carbon monoxide and cyanide, we can do that in our hospital. We can also do organophosphate and carbamate test in our hospital because we know the initial treatment of organophosphate insecticide poisoning and carbamate poisoning may be similar, but after day one, how to titrate the dosage of PAN and atropine depend on which kind of poison is it. So I think the laboratory support is very important for the clinical setting. Thank you.
Okay, thank you, doctor. Okay, the next question would be to all the speakers. Any one of you can answer the question. We would like to ask, is it appropriate to continue run intravenous infusion of N-acetylcysteine if patient develop allergic reaction such as urticaria, periorbital swelling, in which the initial TDM result shows toxic and no metathione available in the setting? Probably Dr. Greg. Thanks.
Yeah.
Well, once we have observed any so-called allergic reaction when we are treating the patient, the best approach is to stop using that at the immediately. That is critical because we are not quite sure if any anaphylactic shock or anaphylactic reaction will happen. Okay, so you must stop that immediately. But talking about acetaminophen poisoning, I don't know, but in the United States, most of the doctors they basically use N-acetylcysteine to treat the patient. But in our country, if it is a very high dose, high concentration of acetaminophen, I like to encourage that you may use hemodialysis. That will be very effective. Just 3-4 hours will be very effective because the volume of distribution of acetaminophen about 0.8 liter per kilo. So that is accessible by HD and also very effective. So one, for example, to me, if any cases, the serum concentration of acetaminophen is more than 250 microgram per ml, it does have the potential not only to cause hepatotoxicity, it may also cause renal toxicity. So in that case, I would prefer maybe just go ahead, use HD to treat the patient. Okay, but HD it's a little bit invasive, right? N-acetylcysteine is basically non-invasive. But as a doctor, as an intending physician, you need to make some judgment, which way will be a better, to the patient. In our country, HD is also not that expensive. I mean, here it's like $200 US, less than $200 US. one run would be good enough. I mean, so it's not that I don't know what the price in your country, in terms of the HD. Maybe if you say, okay, 600 US dollars or even more, that maybe something else. But this is the way which I have been practicing here. Thank you.
Greg, in Singapore, you do HD as alternative?
Hi. We have hemodialysis, but often if we encounter allergic reaction, face swelling, lip swelling, from N-acetylcysteine is sometimes is due to anaphylactoid reaction. So it's not truly something that may develop worse. So what we do is we stop the infusion first, and then give the patient some time, administer antihistamines, and perhaps if the swelling is bad enough, then adrenaline subcutaneously. Then weigh the benefits and risk again. If it is truly a heavy and ingestion, then I think we still need to restart the N-acetylcysteine, but at a slower rate, and observe the patient. It is quite dangerous, but then again, if there are no other choices, then you may still continue because this is an anaphylactic reaction and may respond to antihistamine therapy. Paracetamol, of course, is dialyzable. It's not something that is routine.
Dr. Sabrina, any input from Malaysia? I don't see that we do HD routinely, right?
For massive injection, no doubt the treatment is hemodialysis for us. But if let's say it's not massive, it's a single acute, the level is more than 150 or more than the treatment line. So we will start the NAC. If there's there are studies about 2 bag versus 3 bag of NAC. And there are also, the approach that Dr. Greg actually mentioned, we are also using it if the patient develop anaphylactic reaction, we'll stop, treat, and weigh again the risk and benefit. And then if I need to continue, then we need to continue. Some of the center have the methionine oral, so I have encountered 1 or 2 times whereby the methionine was given instead of NAC in other centers. But so that's about it. Because we must understand that even if, for example, in my hospital, the dialysis slot is quite limited, whereby we have got a lot of end-stage renal failure patients that need to be dialyzed. But of course, if there's an indication for dialysis, we try to push the patient for HD.
All right, there's another question to Dr. Gregory. The question is it routinely or compulsory to send amphetamine or salicylate level for those patients who come with unknown multiple drug injections?
Hi, thanks for the question. It always gets asked because it's controversial. Having said that, paracetamol is one of the most common drugs used in overdose. So it's very common, and there is a treatment available for it. So, and at the beginning, at the early stages of the poisoning, there are no signs except for a bit of vomiting. There's no hepatotoxicity. There's no, not yet. So in order to save the patient, then we do a paracetamol level. And if the levels are elevated, then we think again, we take the history and maybe we can need to restart the N-acetylcysteine. It's very rare, and I think it's probably been published that it is not cost effective to screen everybody for paracetamol. But then again, looking at the cost and whether we can prevent hepatotoxicity, I think we have to weigh that against each other. The other thing is salicylate. Even in Singapore, it's controversial whether we do salicylate routinely. Again, it is even less cost effective. And the symptoms for salicylate poisoning, tinnitus, acidotic breathing, they don't always appear. And in children, they don't say very much. So we cannot assess their symptoms properly. And we have had a number of mishaps where salicylate is missed, and then the next morning the patient is found dead or dying or something like that. So we have had mishaps like that. So yeah, so we do it routinely because you can't rely on symptoms, and it is something that is treatable at the early stages.
Thank you, Doctor. So the next question for dedicated to Dr. Ruth Sabrina is the routine urine toxicology screen must be done for patient with suspected substance abuse, because sometimes primary team like internal medicine or psychiatric insisted for a urine tox to be done.
It is for me, the answer is not routine, because if you know the cost of one urine tox strip, then I think you wouldn't do for every patient that can come to us with, for example, altered mental status. That's why the history, the focus targeted history, and also the physical examination is very important, eliciting the appropriate toxidromes, and after that only we will decide whether the urine toxicology bedside is needed or not. Because anyhow, it is non-confirmatory to begin with, and it cannot be used in a medical legal, I mean in the court also. So that is my answer.
Thank you for the answer, Dr. Sabrina. I think there is
maybe other speakers have their own point of view. Point of care testing for urine toxicology is never been cheap. It's expensive. So
Hi, maybe I can add 2 cents worth. We have the bedside POCT for drug screen, but it takes 24 hours. So by the time something has to be done, so we don't rely on the results, and also the sensitivity and specificity is not there. It's not enough, and so I think it's better to rely on your clinical acumen, save the patient first. Then if the medical people or the psychiatrist wants it, then we can still do it later to satisfy what they need. But it won't change what we do in the emergency.
all right. Any other input from the other speaker, or any other speaker want to give some new input? I think all the question has been answered except for the Prof. Kiyotaka Usui. We're going to you can email to us, and we can forward it to the Dr. Kiyotaka Usui, and we're going to give the feedback later through the email.
Thank you to all the speakers. So finally, we have come to end of our third Emergency Medicine Seminar Series 2021 Webinar Part 1 session for clinical toxicology. We would like to extend our gratitude and thanks to all our speakers for their time to deliver informative and interesting talk. I'm sure the presentation today will be beneficial. Thank you to all the participants, and hope to join you again in part 2 of the third Emergency Medicine Seminar Series 2021 webinar on clinical toxicology on 22nd April 2021. Thank you.
All right, on behalf of the chair, I would like to say thank you so much, Prof. Deng, all the way from Taiwan for joining us and gracing our event this morning. And to all speakers, thank you so much for your input. It was very engaging talks, and I've learned a lot actually from the talks, especially also for us in Malaysia. It's still quite, as Prof. Deng noted correctly, toxicology and toxinology is still very much in the infancy stage. It's very much in the practice side, not so much yet in the how would I say, in the analytical side. So that is something that we perhaps can push for development in the near future. And of course, now we have already started to have a network between experts in the region and not necessarily just in the country anymore. So it shows that the knowledge pool is now, much bigger, and I'm very happy that it can be shared with everybody in the region, and I hope will benefit our patients better. So with that, thank you so much. We will see you again in the next webinar.